This episode is sponsored by AstraZeneca.
Thanks very much for joining us today, Aileen. To kick things off, do you mind giving us a quick overview of yourself and your background?
So thanks a million for having me on, lads. So my name is Aileen O'Meara. I'm the Advanced Nurse Practitioner in St. Vincent's Hospital in Dublin. So my background is I've been working in medical oncology for about 30 years. I started off working in St. Luke's Hospital in Dublin, which I suppose is primarily a radiation hospital where people get radiotherapy. But there is obviously a chemo unit there. So when I started there, I worked in the inpatient ward for a year or two, moved on to their day ward where I worked for about 4 years. And then I moved to St. Vincent's Hospital, and I'm in Vincent's, over 22 years. Started off working there as a clinical nurse specialist, and then about 6 years ago, I changed job to the Advanced Nurse Practitioner in Medical Oncology. So that's where I'm working at present.
What got you into nursing and then oncology nursing? Why did you feel the need to go into oncology nursing?
Yeah, that's good question. I had always had some sort of interest in nursing and looking after people. So I did my nurse training in Cork, down there for 4 years. In the South Infirmary Hospital. Then I moved to Dublin, worked for a year or two in Dublin, then headed off to Australia for a year. Then when I came back, this would have been in the early 90s, there wasn't a whole lot of jobs around for nurses at the time. But I met a friend of mine, I remember in Dunstores, and she was telling me she was working in St. Luke's Hospital and they were actually looking for nurses. So I had never really thought about necessarily oncology nursing, but anyway, I applied to St. Luke's Hospital and got the job. I suppose that started my career in oncology nursing. I worked there. It was a great place to work. I have a lot of good friends still from my days working in St. Luke's. I guess I was in my sort of mid-20s, so we had a lot of fun. But I also developed a love for oncology nursing then. Now, it was a whole different scene back then in the mid-90s when I started my oncology career. We had radiotherapy and a handful of chemotherapy drugs. So, but the whole landscape of oncology has changed dramatically over the years. So, and I suppose that has kept my interest in oncology nursing in that it's been so divisive and so changeable and so interesting to work in.
Of course.
Excellent. Great. Could you tell us more about your role as an advanced nurse practitioner in oncology and like what a typical day looks like? Yeah,
so I'm in this role about 5 years. And I suppose in Ireland, certainly these roles are, 5 years ago, there was only a handful of oncology nursing in the AMP post. So I suppose the AMP role is maybe slightly different in every hospital. Really what you're doing is you're looking at the service need within the hospital. So what I do in the hospital is I do a lot of outpatient clinics, particularly in the breast services, in the melanoma. So I do 3 of outpatient clinics, and then I also do an immunotherapy review clinic once a week for patients who are on immunotherapy, or those who maybe are on a break due to side effects. So I follow them up maybe when they're on their steroids and stuff like that. Yeah, so 4 clinics a week. Obviously also involved in a lot of education, be it my colleagues that I work with. I also give the immunotherapy section review in the HDIP for UCD. And then, multiple sort of outside hospital education sessions for nationally and internationally as well. So it's a little bit of a mixed bag, to be honest. But I suppose the key thing is I'm working as an independent practitioner within these clinics, seeing patients on treatment or who maybe finished treatment and just assessing them for, cancer recurrence or side effects of treatment or whatever.
Okay, very good. Great. So you've been a co-author on the Nurse View. What do you need to know about immune-related adverse events?
Yes.
Can you share what inspired this work and why immune-related adverse events are such an important topic for oncology nurses today?
That project you're talking about was one in association with Medscape. and EONs. So they invited myself, another nurse practitioner from the UK, and it was led by another nurse from Cyprus. And really it was to, I suppose, promote nurse education, looking at specifically at immunotherapy. So I suppose since I've been working in St. Luke's, one of the consultants I worked with specialized in melanoma. So I've always had a grow for melanoma, and as we know, with regards to immunotherapy, this was the first disease that immunotherapy was really used for and benefit, where we really saw benefit. I worked at a time with melanoma patients where really there was very little to offer. Yes, we gave them chemo. Yes, we gave them interferon, but really the survival rate was really low. So when the emergence of immunotherapy really has changed the landscape for melanoma, and I suppose that is where my interest in melanoma or in immunotherapy developed, because I worked with these patients, and then we began to see people living longer, and really it has changed the whole landscape of patients. Yes, we know not every patient responds to immunotherapy, but it definitely, we have people now in our clinics coming back 5, 6, 7 years later with stage 4, previously having stage 4 melanoma. So that's where my interest in immunotherapy developed. When I started out, I remember the first patient that I educated on immunotherapy, and really I didn't know what I was talking about a whole lot. So it was a whole new chapter in my nursing career. It was very different to chemotherapy in terms of mechanism of action, and this was all had to be learned. So I suppose with the Medscape, with EONs, I suppose the focus is on nurse education, because yes, immunotherapy has been around for a number of years now, but there's still a big learning curve there for nurses in terms of managing patients on these treatments.
How do you differentiate between like adverse events on immunotherapies versus chemotherapy? Like, how do you know the difference?
Yeah, it's a really good question. And, not an easy, not straightforward to answer, actually, because it can be very tricky to know, well, if somebody is on combination treatment, because we now know, yes, easier when immunotherapy came out first because it was all single agent immunotherapy. So if somebody came in with a side effect, yes, knew it's from the immunotherapy. Now we have a lot more combination treatments, immunotherapy with chemotherapy or immunotherapy with targeted therapies. So if somebody comes in, for example, with shortness of breath, well, is it the chemo? Is it the immunotherapy that's causing it? So really, it's not always very evident straight off what potentially is causing the side effect. So that is where assessment of the patient is really key. And this is why I suppose education of nurses is really key as well. To try work through looking at different, differentials as to what potentially is causing the shortness of breath. Is it the chemo? Is it the immunotherapy? Do they have a pulmonary embolism? Do they have a chest infection? Do they have progression of disease? So it's really working through the assessment, ruling out stuff. And I think that's how you get to, potentially what is causing the side effect. So it's not always very easy straight off to know, well, which is it that's causing the side effect? So it's kind of process of an elimination, and then hopefully you will sort of target exactly what's causing the side effect.
Okay,
great. Okay. And what are some of the common immuno-related AEs you see, and how do you approach recognizing and managing these early on?
Yeah, so this is where I think nurses are really best placed, and their role is very important, because we do know when a patient develops immunotherapy adverse event, if we can catch it early, we can treat it easier. So as you know, with immunotherapy, it's all about the grading of the adverse events that they have. So I suppose the more common side effects that, I would see in the clinic that I run are skin rashes, hepatitis, patients with colitis or diarrhea, and the endocrinopathies are a big thing. Usually issues with the thyroid gland. So they would be probably the more common ones that I would see in my clinic. A lot of time it may be a grade 1, grade 2, which we can certainly manage at an outpatient level. Very occasionally, the patient might have to be admitted, again, depending on the grade of their symptom.
And is there any, do you use any resources, or like what guidelines do you use to help identify and manage?
Yeah, there is a wealth of guidelines out there. So it will depend, I guess, on your institution in terms of what guidelines you use. We in Vincent's, for example, typically use the ESMO guidelines, but we do know there's the ASCO guidelines. We have the NCCP in Ireland in terms of they have guidelines as well associated with all their protocols for these drugs. It's really about the assessment of the patient. So the other thing that I've been involved with, along with other colleagues from around the country and with the NCCP, is about the assessment. So we all know assessing a patient is very important for these side effects. But what tools of assessment do we use? So as NCLIS is now being brought into the country in different hospitals around the country, they're now looking, I was involved along with, I'm a chairperson for the IO Nursing Forum in Ireland. So that's a bunch of nurses getting together and looking at topics in terms of helping, the safe administration of immunotherapy, and obviously assessing a patient and knowing that a patient is fit for treatment is key. So we developed, in association with the NCCP, an assessment tool. Now they had started it, but it was very chemotherapy focused. So we wanted to bring in, the assessment for these rarer side effects with immunotherapy. For instance, the endocrinopathies, arthritis, because these wouldn't be normally seen. We wouldn't normally have assessed them for chemotherapy. So we've developed this assessment tool sort of based on the UConn's traffic light assessment or the RAG system, where you have green, amber, and red. So the idea is that when a nurse is assessing a patient, they will be using this traffic light system, also in combination with the CTC AE grading system. And the benefit of it is it's to help nurses know, well, what is a grade of the side effect and when does it need to be actioned? So we feel that a lot of time nurses will very well be able to manage a grade 1, maybe a grade 2 side effect. But when it's a grade 3 to 4, obviously then medical intervention will be needed. So it's there to help guide nurses when they're doing assessment. When do we need to escalate the management of the side effect?
A quick question about identifying AEs early on for IOs. Is there any kind of strategies around that? I'm just trying to think. I'm thinking about some of our healthcare professionals that might be listening to this podcast around the world.
Yeah.
Is there anything you picked up?
Yeah. So I guess there are a number of things. So for instance, I run an immunotherapy review clinic. So I'm seeing the patient before each treatment, but they also we also have a triage nurse within our unit. So the patient is given the number for the triage nurse. So again, it's really to do with patient education, primarily to do with patient education, because obviously I say to patients, we can't be with you 24 hours a day. So they have to, if they're having issues, no matter how small, how insignificant they think it is, that they have somebody to call, be it a triage nurse, be it me in the clinic, be it their CNS that they are involved with. And it's really about focusing patients to educate them to understand that the earlier we can recognize a potential adverse event, the easier it is potentially to manage it, the less time they'll be off their treatment. I guess there is this notion for patients, well, I won't tell you about my side effect because I'm worried you're going to stop my treatment. But it's all that, it's all about education and getting patients to understand that that's actually not how it works, and that the importance of liaising with their healthcare professional. So as I say, I have my clinic, and patients get to know me and would be ringing me about this and that. But it is about that assessment, but it is about patient education and sort of working together with patients and obviously with their family. You know, we treat a lot of elderly patients as well. So they mightn't be as clued in terms of using a phone or you know, recognizing a symptom. So it's working with patient, family, and developing that, I suppose, bond with the patient.
Okay.
Very good.
Okay. Yeah.
Very good. And just how do you collaborate with your broader healthcare team in managing immune-related AEs?
Yeah. So again, with this, for example, in Vincent's now, we're beginning to develop pathways with other disciplines. And again, I think this is an area where nurses can get involved. Like, we all know that it can be difficult to get a dermatologist or an enterologist or a rheumatologist. But in a lot of these disciplines, there are now AMPs working within that discipline. So I've now tried to start creating a pathway with my AMP colleague in rheumatology, so that if I have an issue with the patient with coming in with sore joints that I believe is IO induced, I can, you know, refer the patient to her. She will manage the patient, or if needs be, escalate it to her colleagues. So I think it is about developing, you know, a network within your institution with other disciplines, because sometimes we need them. We know the endocrinopathies are a very common side effect. And, you know, we often need endocrine input in terms of how to manage it, you know, the adrenal insufficiencies, the hyperthyroidism. And it is about that pathway. In dermatology, in Vincent's, we have now a fellow in dermatology who will come see our patients. So all we have to do is pick up a phone and they come and assess the patient. So it is creating that pathway, that network within your institution that, you know, allows you to refer these patients on or getting those other disciplines involved when necessary.
Very good.
Excellent. You know, are there any emerging challenges or areas of innovation in oncology that you're excited about or concerned about, for that matter? Any new stuff coming down the line?
So, I mean, there's so much I'm excited about. I mean, yes, the growth of immunotherapy for more diseases in terms of combinations with other newer immunotherapy drugs, with chemotherapy, with targeted therapy. So that ongoing, you know, as I say, when we started out, it was sort of melanoma, and then it grew to lung, and then it grew to renal, and now it's just, you know, all over the place. So that's really exciting. And I think to see the development of immunotherapy in combination with other drugs and with other type of treatments. But there's so much as well. I think the drug conjugate field is just amazing and exciting. And I just think scientists are so clever in terms of how they can develop these drugs and their mechanisms of action. My concern, I guess, is the availability of these drugs. They're just going to be so expensive. So, you know, in Ireland, yes, we are maybe not as good as other countries in Europe or the States. We eventually get there, but there are many other countries around the world that don't have access to all these newer drugs. So I think that is a concern, the availability and the access to these drugs. So because they're expensive, I suppose also, you know, maybe potentially when we're combining all these drugs, the toxicities for patients and stuff. But I guess we work through that as well.
Yeah. Do you ever see toxicities that, you know, are completely rare, or completely outliers in terms of IOs or other treatments? Or are they all common?
No, there's definitely in the IO world, there's definitely sort of rarer toxicities like the myocarditis would be an example of one. We don't see it that often, but it does happen. We know that skin toxicity is quite common, the regular burn or rash that patients get, but very occasionally, maybe once a year, you might see somebody who ends up with a Stephen-Johnson type syndrome. So that is why, going back to the point we were talking about earlier, having these pathways and networks with our colleagues in other disciplines is so important, because I think that has been one of the challenges for nurses starting out, with immunotherapy is, we're not experts in these fields. I've had to learn about, hypothyroidism and knowing the numbers and all that. So, but it's for those rarer multi-organ, very occasionally. I haven't really seen it, but, it's reported multi-organ failure with immunotherapy, patients developing a number of adverse events. And they need to be specialized treatment. So again, it goes back to that networking with and having a pathway. I know here in Ireland, in Beaumont, Jaruska Nadu has developed a tumour board for sort of complicated or rare toxicities with immunotherapy. So again, there you can, refer patients in where there is an expert panel who will look at the sort of rarer side effects and see management of same.
Excellent. Okay. Very good.
And finally, just a hot topic of choice in terms of AI. In what ways could AI help support oncology nurses in managing their caseloads and prioritizing care?
Yeah, God, that's a great question. And I'm not sure, to be honest. It is something I'd have to give a bit of thought to. I know the whole development of the AI world is very exciting, but also one that needs to be managed. I use an app called ChatGPT, which has become my favorite app.
Interesting.
Yeah, really. Like I'm just so amazed about how well it works, how the information you get so quickly. I know there are concerns about AI in terms of, people studying and plagiarism and all that. But I think we can definitely, if used properly, maybe in terms of nurse education, patient education, because it's just at your fingertips. What I'm amazed about that app is how quickly you get the information. So I think it is definitely something to think about. I'd have to give it more thought though.
Yeah. Do you use ChatGPT just for, like Google searches, or do you use it for specific use cases?
Yeah, mainly for Google searches and stuff, when we're on holidays looking for the best restaurant and, But I often, sometimes if I'm reading an article and I don't understand a disease or whatever, I put it in, they break it down so well and stuff. So it's pretty impressive, I have to say.
It is, that's for sure. Yeah, we've heard from other clinicians that they use it for writing referral letters or for helping like with communication, and that's kind of the use case that people mention the most that we've heard.
Yeah, and I know that I've heard, if you were trying to phrase something, if you were doing a presentation and you were trying to phrase something, that I haven't used that myself, but that maybe something that, if you put it into ChatGPT and they'll kind of rephrase it for you or whatever. So
yeah. Excellent. That's it from us. Thank you very much, Aileen. We really appreciate your time and your feedback. Very, very insightful.
Thank you so much, and I'm delighted to be given the opportunity to share my experiences.
Fantastic. Thanks.